we need to. Thank you for attending this conference. Hopefully in the next 45, 50 minutes, I will touch on basic science, clinical aspect, and even maybe get you interested in some research perspective on sickle cell disease. I just wanted to call your attention to that painting on your right-hand side. Ernst Nasser is a 31-year-old gentleman with sickle cell disease, and he's a great painter. And that's one of the paintings he does, expressing his, how he feels and how the disease impacts himself. So I'm supposed to start with a few case presentations. The first one is about a female that marries a male with hemoglobin SF disease that they met while in the clinic. She has a history of pneumonia recurrent during childhood, 3 to 6 vaso-occlusive episodes during the year requiring ED visit or hospitalization, and baseline counts and hemoglobin of 9 and hematocrit around 25. Husband has a past medical history significant for rise of blindness due to recurrent retinopathies, avascular necrosis. Status was his replacement when he was 21. 1 to 3 vaso-occlusive episodes a year requiring hospitalization or ED for management, and chronic pain, mostly related to his avascular necrosis, treated with long-acting narcotic. And they came to the clinic and asked us, okay, we wanted to have a family. What is the likelihood of having a child with the same illness that apparently is a little bit milder than mom? The second case is another female, 38 years old, with hemoglobin SS, history of pneumonias, splenectomy at age 3, cholecystectomy at age 19, frequent hospitalization for vaso-occlusive episode. This time she presented with fetal edema and shortness of breath. And she was noticed to have a SAT of 75% room air. Her baseline is over 95. Increased heart rate, increased respiratory rate, and she had elevated white blood cell count, hemoglobin of 7, which is lower than her baseline. Baseline is around 10, crit of 23, and slightly elevated platelets. She had increased nuclear red cell on her blood film, and she had hemoglobin electrophoresis done that showed consistent with her diagnosis, more than 90% sickle hemoglobin, a little bit of F, fetal hemoglobin, and a little bit of A2 hemoglobin, basically within normal limits. And the question is, what of these findings are more a risk factor for death during the hospitalization? Is the nucleated red cell, elevated fetal hemoglobin, the degree of anemia, and the presence of a peripheral edema? Lastly, the third case is a male with sickle beta thalassemia, history of pneumonias, growth retardation, hand-foot syndrome, cholecystitis, status was cholecystectomy, and a few hospitalizations a year for complication of sickle cell. He was basically fine even with that history until 2 years prior that he developed progressive and very rapidly progressing avascular necrosis that required hip replacement, had an episode of acute chest syndrome operatively, and then after that, multiple hospitalization for vaso-occlusive episode and acute chest syndrome. The labs are there showing leukocytosis, slowly thrombocytosis, and patients have to have siblings. So the question is, what's the next appropriate therapy, basically long-term therapy for this patient? Bone marrow transplant, hydroxyurea, gene therapy, or enrollment on a clinical trial. So sickle cell disease was initially described at the Archive of Internal Medicine 103 years ago, when Dr. James Herrick, as his intern, described this peculiar, elongated, and sickle cell-shaped red corpuscle on a young male from Grenada that was studying in a dental school in Chicago, and he presented with pale, icterus, pain, and when they look at the blood film, and this is really the published see, I think the published blood film at that time show those elongated, sickle-shaped red cells completely different than the ones that we see in a normal blood film. As you know, the hemoglobin is genetically synthesized in based on DNA that is located on chromosome 11, and based on the production of the different globin chains, we as a result have different type of hemoglobin. So during early fetal life, what is being produced based on DNA in the chromosome 11 is for epsilon change. But the hemoglobin A, which constitutes most of the normal hemoglobin, start being produced as early as, the alpha chain, as early as 6 weeks of life. At the same time, there is an increased production of the gamma chain, which constitute what we know as fetal hemoglobin. It's a very stable hemoglobin, but it's not as functional as the normal hemoglobin A. As early as mid-fetal life, but definitely within the first 2 months of birth, we start to produce more of the beta chain, and as soon as 6 months of life, usually the constitution of the hemoglobin is based on 2 alpha chains and 2 beta chains. Most of the hemoglobinopathies are associated with defect on this beta chain, as we see. So when we talk about hemoglobinopathies, we talk about, a defect of that molecule called hemoglobin that is so important in transportation of oxygen and CO2 in the body. Most of the human hemoglobin variants, which are a lot of them, are really non-clinically insignificant. And most of them, as I mentioned, are associated with the structural amino acid changes, either in the alpha, the beta, the gamma, or the delta subunit. Specifically, when we talk about sickle cell disease, a person with normal hemoglobin has 2 alpha chains and 2 beta chains, and that constitutes what we call hemoglobin A. Person with sickle cell disease has a single amino acid mutation in the beta chain in the position 6 that results on all the clinical and morphological abnormalities that we see in this type of patient population. So what we see is that normally the hemoglobin that constitutes most of the red cell, again, 2 alpha chains and 2 beta chains, tend to nicely and homogeneously fill all the red cell. But this, in sickle cell disease, this abnormal hemoglobin tend to pair, especially in situations of low oxygen, in an abnormal way with other molecules, and that become polymers. So instead of being single, very nicely distributed in the red cell, it causes polymers that then result in the abnormal shape of the red cells that we see here. What we see in the blood film again is a lot of cells that are marked with the arrow, but we do see normal red cells. Even though those red cells normally appear in red cells, even though these red cells have mainly sickle hemoglobin, they are in situation of normal oxygen, they can look nice and like concave. But we also see a lot of the nucleated red cell because of the increased hemolysis and the bone marrow trying to compensate with that. And we also see other abnormal shapes such as teardrops and target cells, which I don't think we have any in this blood film. So when we talk about sickle cell disease, we really do not are talking more than one illness, but a group of illness characterized by the presence of that sickle hemoglobin. The most frequent, the most severe, and the one that we see more in the outpatient and the inpatient setting are those patients that have sickle cell anemia or hemoglobin SS disease. And in the next slide, I'll show a little bit about the hemoglobin composition. But we also see a lot of this, what we call the double heterozygous, the sickle beta thalassemias, the SC. In fact, 30% of our active sickle cell patient population have SC. And we also have the sickle delta. Rarely we see the sickle associated with other hemoglobinopathies such as the SOR, which is very common in the Horn, in the African Horn and in Northern Africa. And also we see patients with sickle and hereditary persistent of fetal hemoglobin, which is almost the presence of the high fetal hemoglobin associated with decreased illness, as we will discuss later in regard with the effect of hydroxyurea. So when we do the hemoglobin electrophoresis, which is what we usually do for diagnosis, and is readily available here within 24 hours, and you can even call the tech and they can come over the weekend and do it for you if needed. Again, an adult person with normal hemoglobin will have more than 95% of their hemoglobin composition in A, with a little bit of fetal and with a little bit of A2, usually less than 3%. Patient with sickle cell disease has no normal hemoglobin, have a little bit of fetal that varies from 2 to 10, have a normal value of normal amount of A2, but as again more than 90% of the hemoglobin is sickle hemoglobin. The SC, or the double heterozygous, as its name conveys, basically are 50-50 S and C. The C hemoglobin is a little bit more stable than the sickle, but tend to make the red cell more sticky. So patients with hemoglobin SC disease tend to have hyperviscosity and problems associated with flow in small vessels. So I think in the second case, the father had SC and he had retinopathies and avascular necrosis and complications associated with flow in a small vessel. The thalassemia is given because of the increased presence of an A2, which basically there is an ineffective erythropoiesis, and so there is a defect of the functionality of that beta change production of hemoglobin, and the A1 takes over. The patient with sickle beta 0 thalassemia, for all purposes, are considered like SS because they have a lot of sickle hemoglobin, more than 80%. They have, again, a little bit more of A2 than the normal, but they do not have any A, and that's why it gives them the beta 0, and have theta that can be as high as 20%. And then the sickle beta plus thalassemia, again, most of the hemoglobin is sickle. They do have a little bit of A, they have some fetal, and they have an increased A2. So besides the hemoglobin electrophoresis, we now have other ways to diagnosing the presence of abnormal hemoglobin, including prenatal diagnosis that is available now. And I think most of you either have rotated or will rotate during your first year through the hemoglobin electrophoresis lab, which I think is a good experience to do hands-on activities. In relation with inheritance, is basically an autosomal recessive inheritance, but this gene is present in up to 10% of African American. In some countries like Nigeria and Kenya, 30% of the population are carrier of this disease, so the possibility of having a child either between a person with the disease and a carrier, or a person with two different types of hemoglobinopathies is very high. So in responding to the first case study, the female is SS and the male is SC. So there is really a 50% chance per pregnancy that child will have the same hemoglobinopathy of the dad, but there's the other 50% chance per pregnancy that they will have the hemoglobinopathy of the mom. Okay. So, 20 years ago, the recommendation was for this family, for this couple not to have children because of the high risk, because of the possibility of having a child either with SS and SC. Now, with improved care and all that, the recommendations are that we do educated counseling and that we leave it up to the parents to make a decision, but knowing that this child still have a 30 years less lifespan than a person, an African American without sickle cell disease, and that will have a lifelong complications associated with illnesses. So going more into the pathogenesis of sickle cell disease, that abnormal hemoglobin, it really causes a lot of changes on that red cell. It causes cell dehydration, the polymerase formation that we mentioned. It causes the increased production of reticulocytes, what we call the dense cells, and they tend to have an increased expression of adhesion receptors and tend to become more activated. They have an abnormal, red cells with sickle cell disease have abnormal expression of surface markers and adhesive properties. They also have issues with oxidative damage of the membrane and poor cell-to-cell signaling. This translates into increased dynamic rigidity, which we look at, that causes sickling and increased blood viscosity. The abnormal shape also causes mechanical occlusion and breakage of those red cells that usually only last 30 days, 20 to 30 days versus the 2 to 3 months plus that a normal red cell lasts. The surface markers, especially in regard with coagulation, cause abnormal activation of coagulation parameters and then increased adhesion, especially to the endothelium. But there's also abnormal interaction not only with the endothelium, but with monocyte, polymorphonuclear, and platelets, which we know that is responsible not only from vaso-occlusion, but to inflammation. We recently finished a very successful phase 2 trial where we use a P-selective antagonist on acute pain, a patient presented for acute pain episode, to try to decrease the white blood cell adhesion, activation, and inflammation. And we're planning to, in fact, I've been working very hard with Dr. Telen and the company that supported this trial. We're sending 3 hopefully very good abstract to ASH. Presenting that data, and we're moving forward into a phase 3 trial, because that we were able to show that giving this medication, this drug, early on, when within 18 hours presenting with vaso-occlusive episode, patients have less day on the hospital, less narcotic use, and rapid decrease on the VSA, on the visual analog scale. As a reference of pain. So we'll look for that with those that are going for ASH. Hopefully we'll have a good reception to that. And we were one of the higher enrollers, so hopefully we will be able to be very involved in the phase 3 trial on that. So moving along in regard with the pathophysiologists, Bob Hebel, this is 2004, but it still stands, showed this. It's a mildly complicated graph, but that basically points to the difficult and variable interaction of that happens in sickle cell, and we now call it an endothelial disease because it's just really not only the red cell abnormality, but it's also how the sickling interact with the reperfusion injury, with cause inflammation, how this chronic sickling and abnormal hemoglobin is associated with chronic vasculopathy, and thus abnormal platelet and white blood cell activation, and then coagulation activation. And also we see now the poor balance between the vaso response and the NO and CO2 activity in the vessels and in the cells. So I think I would like you to kind of keep a picture of this picture, because if any of you are interested in research, especially in this area, there's a lot of overlapping area that you can, get involved with that will impact somehow this illness. So this table here basically outlines some of the causes of endothelial activation, as I mentioned before. Some are mainly related with the cell, not only, again, the sickle cell, but the white cells, and in fact, platelet microparticles are a very active area of research, not only in sickle cell, but in coagulation in general, and the effect of platelet microparticles on the coagulation cascade and thrombosis. The other aspect is really the fluid phase of the endothelial activation that has to do with the cytokines, again with the reperfusion, with shear stress, and with deficiency of a cytoprotective mediator, again, one of the most important being nitric oxide. And lastly, there are other causes that basically add to this injury and to this endothelial activation. Some of them we cause, such as iron overload due to the chronic transfusion. Some of them happen, such as bacteria and virus infections and hypoxia. So I'm going to move for the next 10 minutes or so to talk a little bit about the clinical aspect of this disease. This is a classification that Dr. Wendell Ross, some of you have had the joy to meet at one point. He's considered one of the fathers of hematology, and he really was a founder of the clinical oncology department and hematology here at Duke 30 years ago. So he classified the ages as sickle cell of childhood, when infection and strokes are the most the clinical manifestations that are most relevant. Then, for still unclear reason, patients tend to do well between ages 12 and 20. So during late adolescent and early adulthood, means that the immune system is better, so they have less infection, less pneumonia, less acute illness, and they still don't have the chronic vaso-occlusive episode that we see in the young adults. But when you are pretty sure when you were interns and resident and now even as a fellow, what you're going to see mainly is this age. This is the age of the patients that are mostly in the hospital or even in the outpatient service. Our mean age is 37 years old in our outpatient service, even though we have patients as old as 74 years old. And these are the patients that are frequently seeking medical care because of acute events. And then we move into the older adulthood. I don't consider myself old anymore, so I will say adulthood. And these are the patients that are older than 40 and then start having an organ damage issues such as pulmonary hypertension, avascular necrosis, heart failure, all of the above. I have been taking care of a patient that is not even that age, and have pulmonary hypertension, have severe hemolysis, and have a lot of evidence of an organ damage. But we usually see that more in the 30s and a little bit older. Okay, so the hallmark of the disease is pain. That's what usually brings patients to the hospital. Usually 70% of our admissions here at Duke are because of uncomplicated pain episodes. It's a measure of disease severity, so those patients that are frequently admitted and have more pain tend to die earlier. As I mentioned before, it's a mixture of pathophysiology that is associated with vaso-occlusion, from erythrostasis to rigidity to ischemia, but the clinical manifestation is pain. Pain in one side, pain in multiple sides, pain all over. There are multiple predisposing factors that we need to try to address, to identify, and to teach the patient to avoid, such as dehydration, such as psychosocial, such as anxiety and depression. But some of them, they just come about. We have a cohort of female patients that we have them on Depo-Provera to prevent the monthly changes on hormonal due to menstruation, and they do very well. Otherwise, they will have a painful episode and complication every month due to something as physiological as a menstrual period. This was published by Dr. Ballas a few years ago, which basically tried to outline the multiple, both clinical, cell-based, and other precipitating phenomena that is associated with pain. So basically, a pain crisis. So what he described is that patients, 2 or 3 days before they can actually come with present with a pain crisis, they start having what they call achiness, and you will see a lot of patients that tell you, I think I'm going to have a crisis. At that time, again, um, what the presentation that the objective presentation that you can see in the blood film is that there is an increase of reticulocyte count. Usually the platelets usually go up. At the same time, they have worsening anemia because of hemolysis. Then there is like a steady phase where the patient has either more reticulocyte production, increased LDH due to hemolysis, and other changes more associated with inflammation, such as increased CRP and CPK. And then this is usually when we see the patient as an inpatient. A lot of this time within this phase, we encourage the patient and we try to treat the patient at home. We opened, as most of you know, the hospital a year and a half ago here to try to address pain at this level and try to prevent them going to a peak of pain scale and having to be admitted for pain episode. And then there is a time of resolution that really varies between a week to a few weeks. So my problem with this graph is that a lot of people take that as a law, and then by day 6 they tell the patient where your pain should be getting better and you should be going home. This is just a representation of things that happen, not to take it as fact. So just a quick touch on two manifestations of sickle cell disease that brings patients to the hospital, and we usually have to treat differently. One is the aplastic episode. It's usually associated with parvovirus, and that's one of the reasons and with folic acid deficiency, why we keep all our patients in folic acid. But sometimes it can be associated with hypoxia and extensive marrow necrosis. It is an emergency, and it does require acute transfusion, because usually the marrow of patient with sickle cell is hyperactive and hypermetabolic. So when the patient presents with aplastia and have ongoing hemolysis, they can easily go to dangerous hemoglobin and hematocrit levels. The other one that we see less in adults with SS, more in kids or with patients that are SC, is the sequestration episode. In adults, we see more sequestration of the liver, and that is associated with a big drop in hemoglobin and hematocrit. They can present like with an acute abdomen. They present with abnormal LFTs and evidence of acute liver damage, and usually is associated with also with thrombocytopenia and high risk of bleeding. This table here, and I apologize, a little bit busy, but basically outlines out of the major organs some of the, and I can make it available for you if you want to, but highlight major organs that are involved, the clinical manifestations, some of the underlying mechanisms, and what we do for them, from prevention, such as retinopathy, to management early with ACE inhibitors if person have evidence of kidney disease, and also manage of pulmonary complications with oxygen and inhalation and other things. And so mainly these are some of the organs that are involved. The other one that is not mentioned here, but it's important to mention, is brain. Approximately 20% of kids with sickle cell disease will have an acute CNS episode. Now we have the availability of TCD, which is transcranial Doppler, that is done in kids as young as 3 years old and during the whole childhood and adolescence. It allows to evaluate for abnormal flow in the small vessel of the brain, and these kids, if they have this presence of abnormal flow, are considered high risk of a stroke and are put on preventive transfusion therapy to try to avoid the complication of a stroke. When we, as an adult with sickle cell disease, what we see more is ischemic strokes, versus the thrombotic that we see in kids, and those ischemic strokes are associated with red cell, with endothelial damage, and this patient present usually with bleeding, hemorrhagic, and ischemic stroke. And so that's an emergency. We have a few patients that some of you have seen in the clinic that have large sequelae from hemorrhagic and ischemic strokes during adult life. Acute chest syndrome continues to be the first cause of death in adults with sickle cell disease. It's an emergency, and it's basically a syndrome manifested by hypoxia, shortness of breath, chest pain, and the presence of pulmonary infiltrate. This, as I mentioned, as an emergency, needs to be acutely evaluated and treated with oxygen support, with antibiotics if indicated. Mycoplasma is a frequent microorganism in children causing acute chest syndrome. In adults, most of the cases are not infectious related. And treatment with partial or complete exchange transfusion. So the second case that we discussed was that lady that presented with hypoxia, increased heart rate, increased respiratory rate, and a 30% nucleated red cell. So in this case, even though the anemia is important, and the peripheral edema as an early manifestation probably of heart failure, the high nucleated red cells, as I mentioned before, those are dense cells that tend to cause vasocclusion and problem with perfusion, will be what is mostly suggested of increased risk of death. And that's why we do the exchange transfusion. We basically try to take those red cells out and replace with normal hemoglobin, with blood cells with normal hemoglobin. This is just a summary of causes of death in this patient population. In kids, as I mentioned, it's mainly infections, CNS event can cause death up to 11%. Irreversible organ damage is very frequent, and issues associated with hyperesplenism. In adults, almost half of the adult population succumb due to either single or multiple end organ damage, but still CNS events are seen, and acute pulmonary illnesses such as acute chest syndrome are very frequently seen. I wanted to show this slide because even though we have made a lot of progress between 1979 and 2006, before we have a lot of kids dying from this illness or early adults, we still have a peak of death in age 30 to 45. And we still have a significant number of patients surviving less than 30 years or less than African American without this type of chronic illness. So we still have to do a lot to try to improve not only the survival of this patient population, but the quality of life. So the reason why I put these guidelines is because I want you to look at the date, 1999 and 2003. So we don't have up-to-date guidelines of how we manage sickle cell painful episode, even though this is the main reason, again, of hospitalization and illness. The one that we usually follow is, again, it's a combination of both of them. Lynette Benjamin outlined the one that was adopted by the American Pain Society, and that we're hoping to do update in the next couple of years. The potential of both of these guidelines is rapid initiation of therapy, adequate therapy, repeat dose of therapy, and evaluation of and management based on individual needs. If you see our clinic notes for the patient that we see regularly, usually the last part now, due to my history, going to be on the top. We have recommendation for pain management. That recommendation, it has been produced by mainly us, hematologists, not pain specialists, but based on how patients have responded in the past. These are recommendations. So we recommend that providers that are not familiar with this patient population look at this and start the therapy based on that, but that also look at how the patient are presenting during this specific episode and adopt them. We're having a problem with some of the primary care physicians and the interns that they think that that's the rule. What your recommendation say no, 0.3 milligram of morphine, so I cannot give you 0.4. If they're having 10 out of 10 with 0.3, then they need 0.4 or 0.5 or 0.6, and we need to, try to guide our young house staff and other specialists in regard with. We at least have some outlines where we need to really continue to treat patients based on how they are presenting, which it sounds like intuitive, but sometimes it's not. So besides identifying and treating what could be a precipitating or an associated event, the key thing is analgesia, conformation, oxygen, and hydration. Please remember that usually patients may be dehydrated either because they are too much in pain to drink or because dehydration per se caused the episode. But once you are able to hydrate them, it's important to back up on the hydration and just do oral hydration. These patients tend to have heart failure and poor heart function, and it's, especially with 30% of those having some degree of pulmonary hypertension, they easily get into heart failure. And then you take care of the pain, and they stay 3 days longer because of fluid overload. That we need to catch up with that. Again, we all would like to be pain-free, but the goal, at least, of this pain management is to get them down to a degree of pain that they can continue their management with oral narcotics or NSAID or whatever works for them. We encourage the use of PCA because it's something that the patient can have some control on, and that will allow for more active acute management of that pain. Remember, not everybody can do PCA. If they are too sedated, too obtunded, if they don't understand because of cognitive issues, then PCA may not be the best management for them. I like to put this over and over because we need to treat the patient pain. We need to believe them, even if they have a positive, serum for marijuana or for cocaine, which is a 2% of our patient population, or even they're here every week. We need to believe the pain and treat the pain. So when do we transfuse our patients? As pathologists and oncologists, you know that we sometimes give blood just to stabilize or reverse complication, but in this patient population, there's a significant group, approximately 20% of our patients that are on chronic transfusion. It's mainly done for prophylactic prevention of secondary complications, but it's also done on few cases to treat some acute issues. So we usually do single transfusion for hyperhemolytic stages, for sequestration and a plastic episode, sometime in preparation for surgery, and patients that have severe anemia during pregnancy, we treat them with single transfusion. And again, they tend to be episodic to stabilize or reverse complications. Those that know us, Regina and myself and Nirmisha, know that we are stingy with transfusions. Blood transfusion really, as you know, has multiple secondary effects, iron overload, autoantibodies, etc. So the other thing that we try to have in all our notes is the patient baseline levels. So you will see a hemoglobin SS patient that have a baseline hemoglobin of 7 and another that have a hemoglobin baseline of 10. So that is 7 doesn't have to have a hemoglobin of 10. They are okay with 7. They do well. That is 10 and can come with a hemoglobin of 6 and is hypoxic, then needs a transfusion to get them back to wherever they are or close. So it's important to, again, evaluate patients individually and manage them based on their baseline and how they're presenting with. Exchange transfusion are usually done on an emergency basis, although we sometimes do it in preparation for major surgeries, i.e. surgeries involving the CNS, abdominal cavity or pulmonary. Small surgeries, minor surgeries, really there's no indication for exchange transfusion. But the main reason for us to transfuse patients in the outpatient clinic exchange regularly for a history of CNS event. And the goal is to keep the hemoglobin Sickle less than 30%. And again, the main one that we see as an inpatient is during acute chest syndrome in the hospital. Sometimes we do it for intractable priapism. Sometimes we need to do it for pregnancy. I would like to, finish with talking about some therapeutic targets, and I think that I'm getting short time, but based on the picture that I mentioned before, there's a lot of different areas of research in sickle cell that I would like to mention some more of them. The only approved drug for treatment of sickle cell is hydroxyurea, which basically is we use it for in the basis of trying to inhibit the production of sickle hemoglobin and then the polymerization that happens with that. So the next few slides talk about hydroxyurea. As you know, we use it a lot for other neoplastic and non-neoplastic diseases. It's been used very commonly for more than 70 years. In relation with sickle cell, basically we use it to try to shift the erythroid precursor differentiation and thus increase the production of fetal hemoglobin. We know that is represents an increase of the red cell hydration and increase of the deformability of the red cell. But you know that hydroxyurea is a cytoreduction, and that especially white blood cells tend to, when in high number and activated, cause normal adhesion with red cells. So hydroxyurea is also used for that. And in fact, the goal of therapy is to make the patient a little bit neutropenic and a little bit thrombocytopenic. And but hydroxyurea also is involved with generation of NO and also with production of erythropoietin. So this is just to show the production of hydroxyurea research. We have been involved with that research since 1992. Dr. Ross, and then I follow on this study, the pivotal MSH study that supported the approval by FDA in 1998 of this drug. Right now, Russell Ware, that we used to be here, and Corey Thornburg, that just left Duke last month, are the leaders of the studies in kids, and we're hoping that by next year we will have approval for hydroxyurea use also in children as young as 3 years old. It's now used off-label as standard of care. So the initial study in which we participated basically was a multi-center trial that showed that hydroxyurea therapy was associated with much less cumulative event, i.e. painful episode, than therapy with placebo. And this data caused the study to be halted early and for rapid fast-track approval of the drug. Together with the decrease of the cumulative event of pain, patients that were on the hydroxyurea arm had less acute chest syndrome episode and needed less transfusions. So the official approval for hydroxyurea is for those patients that have more than 3 painful episodes per year to reduce the frequency and intensity of those painful episodes. We follow up with a study that we did 9 years after. This is a 9-year follow-up on the same patient population and looking into the long-term therapy of hydroxyurea. We were able to show that hydroxyurea was associated with 40% reduction in mortality, and that those patients that kept a high fetal hemoglobin did much better than those that have a low fetal hemoglobin. And again, the presence of acute chest syndrome and the frequent painful episode was associated with mortality. And again, the reticulocytosis, so the high reticulocyte count, was also associated with more mortality. Lastly, we published this study in 2000, I think that was we published a follow-up again in 2009, which was patient follow-up of hydroxyurea for up to 17 years. And basically what we show is that, again, long-term treatment with hydroxyurea was not associated with malignancies like we see in PVERA and other patient population treated long-term with hydroxyurea, but that was still, again, long-term accumulative benefit of hydroxyurea. The problem with, so when this patient, the case number 3 of the patient that presented with more pain, avascular necrosis, acute chest, and worsening anemia, the best therapy is hydroxyurea, and that patient should have been maybe on hydroxyurea earlier than that. Bone marrow transplant, it's still in research stages. We have an active protocol open here together with Dr. Sullivan doing bone marrow transplant in young adults. Gene therapy is lagging behind in regards with, the expectation of this being a therapy for sickle cell disease. And as you know, we have multiple clinical trials, but patients like this one will benefit for standing therapy with hydroxyurea at this point. This is just to mention that we do have a bone marrow transplant project, and I think a couple of you may be involved with that. It still is reserved for those patients with poor prognosis or with significant sickle cell morbidity, because adults that have been transplanted with sickle cell so far have had a lot of complications. But now we're looking at instead of a myeloablative treatment, we're looking for a chimeric type of treatment where we're trying not to really eradicate all the sickle cell, but make this patient a chimera and sickle cell trait, with the expectation of them having less GVH and less long-term toxicity from the water-related process. But this data here show that even those few adults that have been transplanted have a high survival, a high event-free survival, and a low possibility of rejection and recurrence. These are just an outline of the indication for the study that we have currently here at Duke. We have one patient that has consented for the study, and we also have a control arm that we're looking into compare those patients that are not candidates for transplant, but that from the economic point of view have a high hospital utilization. So I wanted to conclude to remind you that this disease represents years of pain and suffering, a lot of multiple organ functions, a lot of psychosocial issues. A lot of these patients do not work or cannot work, have difficulty maintaining the job, and it's a very costly disease. One of our patients, a lot of you may know him, he just paged me today. He's in the way to the emergency room. But 2011, he was the patient that had a higher cost to the Duke Hospital, which is nothing for me to be proud of. He does have a lot of psychosocial issues that have been addressed, and that now he's doing much better. But he has a lot of complications of this illness, and it's a big problem. As I mentioned before, this illness is associated with shortening lifespan. So I want to conclude with this. Well, there's one more slide, but this is try to really show within this adult population with sickle cell disease the complexity of the biological groups of care. The disease per se is severe. The psychosocial impact of the disease is important, and also the system of care, which we're trying to improve, is also very limited for this patient population at this point. But since we are clinicians and researchers, I would like to encourage you to look into the research component. And again, there's a lot of going on, but there's a lot of opportunities for research, both at Duke and outside. This is a rare disease. This is a small patient population, but there's a lot of funding that is available for this that you, if interested, you should look to that. I think that's what I want to discuss today. Sorry, I just kind of ran over the time. Questions?
I have a question. Is there any reason you would not give hydrea to someone with sickle cell?
That's a great question. So the quick answer is no. All patients, and most of our even FC patients, which is not one of the FDA approval, we give hydroxyurea, especially those with chronic pain. There's a lot of issues with adherence to hydroxyurea. There's a lot of fear, both from the patient point of view, from general providers about hydroxyurea, given the teratogenic effect, given the long-term malignancy association in regard with CML and PML treatment. So the quick answer is no, that we should be given to offer to everybody, but we have a lot of patients that reject it. We have a lot of patients that we start on that and send them to the community, and then their physician, their primary care physician, will not follow with that because they're not comfortable managing that. In fact, Dr. Dr. Ware and Courtney Thorburn, Lermisha offer to every kid that basically comes to their 3 years and older at this point.